There's no more mystery in angioplasty. We don't guess what we're doing. With optical coherence tomography, intravascular ultrasound, and physiology, we can use precision to make sure that we have the right size stent, the length of the stent, assess morphology, and get the best results with the least complications.
I've been involved with intravascular imaging literally since its inception. And I think the revelation that came to me when we first started doing it is for the first time, even though we work in arteries, we finally could see the artery. Up until then, we were just looking at the lumen, just the inside of the artery and not the actual artery itself.
What is precision PCI? In my mind, precision PCI is going in, knowing exactly which of the lesions, which of the blockages needs to be fixed, because the angiogram does not tell the whole picture. I think we need a proper physiologic assessment, a physiologic map, in fact, of all the lesions in the vessel to understand which of those are causing a problem, and then fixing those, only the ones that cause a problem, leaving everything else alone.
Here at St. Francis, where the use of intravascular imaging and physiology is routine and part of the standard practice, you really see how it impacts every single case.
I'm Dr. Chuck Lucor, President of St. Francis Hospital. Our interventional cardiology team, with their intravascular imaging tools, are really driving the precision of interventional cardiology.
Before, I used to put stents into arteries, but now with precision angioplasty, we have an algorithmic approach to put a stent in a patient's vessel so that we get the best results possible.
St. Francis Hospital is the #1 enroller of Illumian 4 in the world, and we're proud of that, and we're proud to be a major establishment of future clinical trials, such as that DEFINE GPS led by my colleague and friend Alan Jeremias.
So I get asked a lot, is it really necessary to do this imaging in every single patient or do physiology in every single patient? And my answer is this: when we don't do these precision measurements, we can estimate and we have a pretty good idea, but it's not the same precision work as we usually would have when you actually do an intravascular imaging study. You know exactly the sizes, the locations you want to place the stent, and then of course you can expect the perfect result.
Dye goes in the artery, or contrast, and you see the contrast flow through the artery. It tells you nothing about the morphology of the artery. You have no idea what's inside that artery. Is it calcium? Is it fibrotic? Is it lipid? You don't know the exact length of the lesion, but I couldn't tell you, looking at this screen, the length of stent that's necessary to cover that whole artery. With imaging, I have exact measurements to the millimeter to tell me how long a stent I need.
Intravascular imaging lets us look inside the artery, to look at the morphology, to look at the plaque details, to determine exactly how long your stent should be, to determine exactly how wide your stent should be. And so what we're doing is moving away from a sort of one-size-fits-all or off-the-rack approach to really a custom tailor-made fit.
Over the past few years, we've had a number of advances with invasive physiology. We now often do non-hyperemic pressure ratios to assess physiologic significance, often not requiring the use of adenosine. There's also been advances in pressure wires where invasive physiology wires can now be used as standard workhorse wires.
And I think there's some really exciting things coming up in intravascular imaging and physiology in the future. First of all, the ability to leverage artificial intelligence and use that to sort of pick up many of the things that we had to do manually in the past. They'll now all be done automatically. The ability to leverage very large data sets from around the world to understand the clinical implications of certain findings, either by imaging or physiology, is on the forefront.
And the progress in this area has been astonishing and has really transformed interventional cardiology.
And so now it's become routine, and it really doesn't take a lot of extra time. It's part of the procedure, and we're all happy because we're satisfied we have a perfect outcome.
And the people who are profiting the most from this are the patients, because they're getting great long-term results.
Our goal at St. Francis is high reliability of care, and our interventional cardiology team, through the intravascular imaging tools that they are studying, using daily, and publishing on really are making our care safer, more reliable, and is consistent with the whole theme of our hospital to be the highest quality, safest, and best experience for care in cardiovascular medicine and interventional cardiology in Metro New York.